of the procedure. So integrity of this conductivity by even though visibly you're preserving them anatomically. So that is one concept as students we need to learn early enough, that anatomically preserving a neural structure is not equal to functional integrity being maintained. And that can only be assured if there is a good neurophysiological monitoring. Now that's fine as long as we are dealing with extraaxial tumors. What about deep-seated tumors like this? The microscope can't see a tumor which is so deep inside. Once you've done a craniotomy, you will be only seeing the brain surface. So how do you go inside, where to make the incision, where to make the corticectomy to go in? So this was to be made, whether the Sylvian fissure is exposed or not. Are we the superior temporal region? Are we in the opercular region? Are we going through the supramarginal gyrus, angular gyrus? Will the patient have speech deficit? So all these doubts can be clarified if we can have a good navigation through from a point of entry to the target. And that's why navigation has come a big way, just like a car GPS. You can now see on surface where we are entering and see exactly what the trajectory will be to enter a deep-seated tumor. As you can see here, the lines that show you, this is the area of entry and this is going to be the trajectory that we are going to come through. So knowing our and we are all used to navigate, all neurosurgeons are practicing this in a manner that the learning short. When navigation came in, we were worried that if the students learn through navigation, what if they work in an area where navigation is not available? But one should understand that learning a 3D anatomy to a level where you can use without navigation is a long learning curve. It's very steep. But if you use navigation and if you use your mind at the same time while you're navigating, you understand the 3D anatomy much faster and the learning curve becomes much shorter. And the mistakes for which the patient has to suffer becomes far less. Only problem with navigation is that there happens to be a brain shift. As you can see here, this is a tumor which has been resected in this. And then when you see this structure, which is the motor cortex, see how much it has shifted following the resection of this tumor, because this compression has gone. So this distance has dilated by almost half a centimeter. So if you are going purely by navigation, intraoperative, a big tool. Not only MRI, you may use intraoperative ultrasound, which can be useful, which has its own limitation. Intraop MRI definitely is expensive, but can be used, can be modified as we have done over at our hospital, where the patient can be in the next room. Unlike this brain suite where patient and the magnet is in the same room, we have adjacent room and when the operation is done, and we can wheel the patient into the MRI whenever required. And the MRI can be used for routine radiological purpose when we are not using the MRI for operative purpose. So using that kind of an MRI, it's quite cost effective. And we all need to have just the intent and the time to do it. Where is it useful? It's useful in all types of surgeries. You can use it in brain tumor surgery, extraaxial, intraaxial, pituitary surgeries, in movement disorders, it's like for DBS to check the location of the electrode. You can use it in epilepsy surgery, tumors, etc. Once you have the tool, the indications can be as many as you can find it to be useful in. Now I'll give you all examples of all this technology that have been used in various tumors and how they complement each other. It's not just one technology. It's not just if you have intraop MRI, you can do maximal safe resection for all patients. You need to use the pre-op image. You need to study the DTI images for seeing where the tracts are. You may have to do an awake craniotomy to see where the functioning tissue is, you may have to use intraoperative imaging, you may have to use fluorescence, and you may be using monitoring and mapping. So all of these give different information, and I'll show you how. So if you take eloquent cortex, as we see here, the speech area, the motor area, the post cortex, this is the mapped areas as per the popular eloquent functions. It doesn't mean the interconnecting tissue is not eloquent. They are also eloquent because the connectivity is very important. The connectome is as important as the areas in which the nerves originate. Now, how to identify first the areas in which the nerves originate? So this is what we do once we have done a craniotomy. We stimulate with a monopolar cortex or bipolar and identify what is the function of this cortex, and then avoid these areas and try to find a corridor which is silent, which at least is not eliciting a function. So we do not willfully give a functional deficit to the patient. Now, do we have to do craniotomy always to identify which part of the brain is functional? That comes the beauty of imaging. Now you have functional MRI based on the blood circulation that increases to the cortex at the time of a particular function. The areas of the cortex will light up, showing that these areas of the cortex are more active when a particular task is given to the patient. This patient had come to us with a left trigonal tumor, and we had to make a left-sided approach to this patient, transcortical. However, we were not sure where the speech area is, and we didn't want to land up in the same patient who did not have any speech deficit. We didn't want to give the patient a speech disorder post-operatively. So we just got a functional MRI done, and lo and behold, you see all the areas lighting up are in the non-dominant hemisphere. It is in the right hemisphere. So practically the left hemisphere is clean. There are no areas functioning for speech on the normally dominant left hemisphere. This patient has the opposite hemisphere, which happens to be dominant, which is very, very favorable, and we could directly go in and operate without any difficulty. In fact, this patient had been refused surgery in another center, saying, if you get operated, you will lose your speech, and they were very afraid, and they had to come to us to take a second opinion. And after this MRI, when we told them, you will not have any problem with speech, they were in fact very thrilled but quite surprised that how that conclusion was made without even seeing where the origin is from. So preoperative imaging and interpretation of them makes it very critical. So this is the intraop image of this patient. We have gone through the left side temporal. We have been able to resect the tumor completely, intraop MRI. And this is the pre-op, and this is the post-op scan showing complete resection of the tumor without any deficit. The patient could be treated effectively. Again, this is a motor cortex lesion. Patient had speech problems and has got limb problems, upper limb, because it's in the supralateral surface of the homunculus. Again, if you don't attempt it, it appears eloquent cortex glioma, non-resectable. What would have been done is either wait and watch or a biopsy. So we decided to go ahead with functional MRI. As you can nicely see, the area of the tumor is free. Antro-inferiorly is the speech area lighting up, and this is the motor area. So it's quite deep-seated, and we have done with the awake craniotomy. So you can see that the patient is awake. We are using awake, asleep, awake technique. At this point, we are stimulating to check whether there is any movement. And you can see that there are facial twitchings happening when there is a stimulation we are giving near the cortex. And you can see in this image, we are also checking where we are stimulating in navigation, where exactly the position is. And you can see here, while we are stimulating in that region, the hand is twitching. So we know that we are at the hand area, and we proceed more carefully. This is the suction monopolar cautery that we use to achieve that while we are doing in the subcortical area. So as we are sucking out the tumor and the blood, the tip, which is not insulated, keeps stimulating the deep white matter. And we know roughly the 1 milliamp to 1 millimeter distance. So we stimulate at 10 milliamps. So we are roughly about a centimeter away from the white matter tract, which is eloquent. We get a signal, and we know that we are nearby that region. So with this, we were able to resect, almost giving just 1 centimeter gap from the eloquent area where we got facial and hand movement, but we were able to remove more than, say, 70% at least of this tumor, which would make a definite significant impact on the progression-free survival of this patient. This is another example where studying the tracks before surgery helps you plan the surgery. This had been already resected cavity in an area of a low-grade glioma, which appears to be in the motor area going into the parietal cortex. So he has been operated elsewhere and the parietal part of the lesion resected, and this was considered to be low-grade. But we do know from experience that the tumor can be heterogeneous, and there can be areas in the tumor that can be grade 3 or even grade 4. So unless you have most of the tumor out with the pathologist, you can't be sure that you're dealing with a grade 2 tumor. With almost 50% of residual tumor, this patient was advised observation or wait and watch or go for radiation. And they were not able to decide. And so they had come for a second opinion. And we had done a perfusion scan, and the perfusion scan showed this area lighting up. That means this area is hyperperfused and could be malignant. When we did a DTI, all the fibers are displaced anteriorly. That means all the motor cortex and the connecting fibers are anteriorly displaced. The posterior root seems to be safe. So we went in back again from a posterior root. We resected more of this tumor anteriorly. We stopped the procedure when we thought we are about 1 centimeter away from the motor cortex. When we got subcortical stimulation, we did intraop MRI. We had some more tumor that was left, which could be resected. Patient, meanwhile, had developed a deficit, thankfully improved by the time we completed the intraop MRI. That means it was not a permanent damage, it was only a mechanical distortion induced dysfunction. We could confidently go ahead and resect that extra piece of tumor, and we could establish a diagnosis of grade 3 glioma in this patient without giving him an additional deficit, which made this patient go directly for radiation and preserve his functional integrity. Nowadays, even further, mapping of the cortex without direct stimulation has been achieved with transcranial magnetic stimulation. So this gives stimulus in the intact cranium, and you can find out areas of speech like this in the opposite side of the tumor, or you can find out areas of stimulation where the speech is affected and where the speech is not affected. So accordingly, in this patient, as you can see, speech area was here, and all these dots were not related to a speech deficit. So we knew directly over the tumor, there was no area of speech, and even one could go directly and resect this area of the tumor without giving a deficit. Now, this is what is doable even before doing the craniotomy. So you know, when you did the craniotomy, at times you need not even keep the patient awake. You can directly go in and resect the tumor without having to struggle for locating the speech area. Sometimes you may have false negatives like a wrong technique, or patient may not be cooperative. In those cases, this becomes very useful. So this is for localizing the cortex. Now, how do you localize the deep fibers? Now, previously, we used to see the deep fibers only in anatomical specimen in the, say, autopsy pathology lab. Now you have beautiful diffusion tensor imaging. All the tracts, you name the tracts, your arcuate fasciculars, inferior frontal occipital fasciculars, your uncinate fasciculars, your corpus callosum, corticospinal, all can be seen beautifully in different colors in the pre-op image. So once you identify them, you can easily navigate yourself, preserving these tracts and directly going to the tumor and resecting it completely, preserving all the tracts around the tumor. So white matter tract preservation has become the current standard of care, not just preserving the cortical surface or the nerves. Now, I showed you transcranial magnetic stimulation. These were the points as given by transcranial magnetic stimulation. You can extrapolate these points by fiber tracking. So this is transcranial function-specific tractography based on neuro-navigated transcranial magnetic stimulation. So you get to see, not just based on diffusion tensor imaging, this is based upon stimulation by transcranial magnetic stimulus. So this is more specific, and these fibers are going to be more specific for functionality and knowing where these fibers are spread around the tumor, one can make a more safe maximal resection that can be done. So once these fibers are identified, you can resect the tumor, and when you are in doubt after the surgery, whether this is optic radiation that has been injured, have I resected close enough to the optic radiation? In the intraop MRI, you can identify that region, that it is still a thin part of it is left out, beyond which we have removed all that is on the surface, and that area also can be resected safely, preserving the deep structures. This is an insular lesion, again showing the corticospinal tract in the posterior part of the lesion, and this is the arcuate fasciculus, and the tumor is nicely nestled within the arcuate fasciculus. So preserving the corticospinal tract and the arcuate fasciculus, one can integrate navigation, preoperative DTI to the intraoperative scenario. So this is again another example where the corticospinal tract is seen here, insular tumor, again resection cavity and postoperative images. Now you can see how it changes. This pink area, what you're seeing here is the corticospinal tract, and you see after some decompression, how it has expanded and come more closer to surface. So if you go purely by navigation, you will be misled. So this is where the importance of having an intraoperative imaging that becomes important to see how these things dynamically change as you keep removing the tumor. Here, another example of a corticospinal tract, which is being nicely deviated by this lesion sitting out here. You can see that it is pushing the corticospinal tract. This patient indeed had a deficit, so there is no way you can do a functional intraoperative mapping because patient already has a deficit. So you cannot elicit an in and away craniotomy movements because patient already has a problem. But as you can see in the DTI, the fibers are still preserved. That means it's because of compression. So you need to resect this, but preserve these fibers. That's all the main aim is. So that's what we have done. It has been resected using fluorescence guided. I'll show you the fluorescence later. This is the post-operative image. And then you can see the post-operative DTI where the tumor is removed, the fiber tract is preserved, the compression is gone. This gives maximum opportunity for the patient to recover in the post-operative period with good rehab care. So you can see here, preoperative, compression, tumor resected, post-operative, no compression, the DTI showing good fiber tracking. Now, fiber tracking can also be useful in planning your surgery. So we know that if you go perpendicular to the fibers, you have maximum. If you go parallel to them, you are likely to have less damage. So we plan craniotomies to enter into, say, a frontal location by planning the trajectory so that you go parallel to the fronto-occipital fasciculus, the SFOF or the IFOF if you're coming inferiorly. And this patient, incidentally, left-sided tumor in the speech area, we found with functional MRI that the speech area is actually displaced downwards. It is in the deeper part of the tumor. So combining navigation, preoperative DTI, and intraoperative monitoring, we could identify the area where the deep part of the eloquent speech cortex is. Preserving that part, we could resect rest of the tumor. And here you can see the arcuate fasciculus being far away. So this is how we have mapped the speech area on the surface. This was the silent area in between. We are making a cortisectomy and operating. And this is at the end of surgery, resected with the deep area, which was navigated and preserved. He indeed had a speech arrest when we stimulated here. We could preserve his speech completely. And this one turned out to be a grade 3 anaplastic oligo. And he was sent for adjuvant radiation without any fresh deficit. Otherwise, he would have been deemed inoperable because it is on the speech area. Now, not just intraaxial lesions. In extraaxial lesions like a meningioma, if it is basifrontal, compressing on the optic nerve, you can even monitor the visual pathway with VEP, and you can even monitor third, fourth, and sixth cranial nerves if you are operating on a cavernous lesion or a brainstem lesion like this, where you want to preserve the third nerve, which is coming out in the interpeduncular system. If you're doing a CP angle tumor, one could do a corticobulbar MEP and then make sure that all your brainstem is intact and all the lower cranial nerves can be monitored using corticobulbar potential and direct stimulation of the lower cranial nerves, 7, 8, 9, 10, 11, and 12. So preoperative imaging, understanding the tracks, and peroperative monitoring. You can almost all functional neural tracks can be tracked and mapped or monitored. Relevant anatomical and physiological understanding is very essential, and this helps limit the damage and preserve safety, not only anatomically but also functionally. It's important in prognosis for recovery. Even if patient wakes up with a deficit, and if we have electrophysiologically preserved the tract, we can assure the patient that this is likely to improve, put our resources on rehab, care, and physiotherapy, and within a few weeks, the patient will be back to normal function, which is very critical and essential. Now I'll show you some difficult areas like, say, the insular cortex. So insular cortex is one of the island of Reel, covered by the frontal operculum, the temporal operculum, and you have the IFOF and you have the arcuate fasciculus. So there can be a lot of damage done by going through normal cortex if you don't know where these are displaced. So diffusion tracking and identifying your area of entry has become very important in insular area. Like in this case, the arcuate fasciculus is nicely around the tumor, and such large tumors can be resected in the dominant hemisphere with supramaximal resection, giving a large cavity like this, but still preserving speech function, which would have been unheard of in maybe 1 or 2 decades ago. So similar large lesions like this, one can study preoperatively. Here, large lesion looks almost unresectable, but intraop MRI shows us that we still have a lot of lesion left anteriorly, which is also resected, and patient has a decent cavity with majority of the tumor totally excised, and these patients tend to have longer progression-free and overall survival. This is a tumor again, which has been resected before the insular part of the tumor has been left behind. Again, a major challenge, how to resect this. So we use navigation here to guide us which part of the tumor to remove. So how do you know where you are while resecting the tumor? If you have outlined the tumor in the navigation under microscope, you get to see the margins of the tumor very clearly like this. So this is the temporal part of the tumor, this is in the insular cortex, and this is the deeper part of the tumor. So you stay within these margins, and these margins tend to change as per the focus of the microscope, showing you exactly at that level where the tumor is. Especially if they are infiltrative, you have no other clue but tactile feel of how the tumor is feeling if it is rubbery, and then navigation which can assist you. Of course, brain shift is a problem, so one has to use intraoperative imaging added to this to make sure that you are not causing a problem to the patient. So this was the image, preoperative. Using navigator guided resection, you can see how much we are able to make inroads into the insular area, leaving but the deep part, which is likely to be next to the internal capsule. This kind of large multi-compartmental lesions, a big challenge without intraoperative imaging. You see, we have resected very well the temporal lobe and even the insular cortex, but a lot of tumor going in this prong-like fashion can be removed only when you do intraop image and see that they are there, and then you go ahead chasing them and remove them further. Then you are able to achieve a good resection. It's worthwhile in low-grade gliomas as these are slow growing, and you may extend their progression-free survival significantly longer. With more and more studies, we now know that with the favorable group of genetics, extent of resection being adequate, these are the only 2 prognostic features along with age. So now I move to fluorescence, where we can see that on the surface, this is looking normal white light brain. And if you give a yellow fluorescence, this is how the tumor area looks. So we can use fluorescence, which we have in our microscope. You just give the yellow fluorescent dye, the tumor fluoresces, and you can resect very well. This is very useful in deep-seated tumors too, where the margin is fluorescing. You can see excellent resection achieved. How we are able to achieve this is only because the fluorescence of the blood-brain barrier breached areas, which is contrast enhancing. So I'll just show you this quick video of fluorescence where there are a lot of criticism to yellow fluorescence because people say that it washes out and it may be too difficult to delineate, but you can see clearly here deep-seated margins of the tumor exactly fluorescing different from the surrounding tissue, which is not fluorescing. It's very good in metastasis, very good in enhancing tumors. Of course, it's not useful in diffuse infiltrative non-enhancing tumors. And if you are given at the right time and the right dose, you can see rest of the brain doesn't fluoresce, and you need not worry about the pia arachnoid and the dura which fluoresces. We know there is no blood barrier there, they won't fluoresce. We are only interested in the tumor margin within the brain, and there it provides excellent contrast to normal brain, and you can beautifully achieve a total resection of contrast enhancing margin without fail in almost all the cases that you use yellow fluorescence in. Now, apart from yellow fluorescence, that is the popular fluorescence of ALA. Now, ALA is active fluorescence. So I'll just show you how ALA looks. Unlike the regular light like looking in the yellow fluorescence, you look here, the entire area looks blue and the tumor looks pink. So this is good contrast for tumor to non-tumor, but you don't know if you are going through infiltrating cortex, because you may walk through infiltrating cortex, which are active tumor proliferation, and rest of the area looks dark or blue. So achieving hemostasis becomes a problem as against yellow fluorescence. So the difference between yellow fluorescence and ALA fluorescence, this is pretty expensive. This is very cheap. This depends on physical blood-brain barrier. This depends on the malignancy of the tissue. This is active metabolic fluorescence. This is just passive fluorescence because of lack of blood-brain barrier. Edema and physically disturbed areas may fluoresce late, whereas peritumoral infiltrating areas may fluoresce actively. And so you may walk into functioning tissues surrounding which are infiltrating if you are not careful. So here, this economical, it's a very effective adjunct, provided you can use it safely. Trials are on to compare and contrast between the two. Of course, it's very useful where one can use it safely. And there are plenty of publications as of today which have shown the benefit of yellow fluorescence. As you can see here, even irregularly shaped tumors are well resected without any contrast enhancing part being left behind. Another example of peripherally enhancing tumor, deep-seated, you see, blind areas can be left behind. So not only using fluorescence gives you a guarantee that you have resected completely. Intraop image will pick up the blind areas where you are not able to see. So once you see this, you can go back in and remove it. So always intraop MR, if available, should be used as a gold standard at the end. Only thing is it will delay your scan later. So you did not have a lot of tumor left behind. You need to do very less amount of work after the intraop MRI. In our initial 93 cases, which we had done over 2 years, we realized of only infiltrating glioma, residual tumors were seen in intraop MRI in more than 40% of cases. And final subtotal resection of the residue left behind was only 8%. So 92% of the cases, we are able to achieve gross total resection. Not only just gross total resection, see the surrounding area which contains edema. If you are aware of Raymond Savaya's article, which said 50% of resection of this surrounding white change in T2 may enhance progression-free survival further because they may have tumor in it. How do you identify? You have to do perfusion scan. So we have resected, we have done a perfusion scan. In this white area, you see these areas of hyperperfusion. So we have gone back in again and resected those areas of hyperperfusion, thereby thinning this white margin out, thereby enhancing again problem-free survival of these patients. So now, intraop MRI role in glioma surgery is not only for resection of tumor, it is also for preserving fiber tracts and functional imaging like eloquent cortex preservation and tumor resection by perfusion imaging. So all can be done, especially if you have a higher strength magnet like a 3 Tesla MRI, which can do all these functions, unlike say a 1.5 Tesla, which may limit you to doing only a T1 and a T2 in a brain suite kind of a model. So in conclusion, I would say maximum safe tumor resection can be achieved by integration of all the technologies we have at present, like a microscope, good preoperative MRI with diffusion tensor tracking imaging, intraoperative imaging like ultrasound or MR, use of navigation, fluorescence, and for functional safety, good use of intraoperative electrophysiology. Though the initial investment in some of these may be expensive, in those cases where we can achieve good resection, these are invaluable. So these will be good investment for neuro-oncology center, which wants to achieve maximal safe resection and give the benefit of modern neurosurgery to our patients so that they live longer and they live better with a higher quality of life till whatever short period of time that they have suffering from these miserable diseases. So we should be a very important catalyst in giving them this opportunity. And for that, we should not leave any stone unturned. And please, my request to all the DNB students, all the students who are listening to this, get an expertise, get an exposure to all the technology that you can, and try to use whatever you have at your disposal to make the patient life better and worth living. Thank you so much for your attention.
Thank you very much, Dr. Anand, sir. I think it was a fantastic lecture, and it was so interesting that, I'm sure if any of the DNB students who are non-neurosurgical also are listening to this talk, it will really open up their eyes, because the way the technology has come into play and how it is helping the surgeons navigate through the most complex of structures, that is the brain, and do surgeries which are not going to leave any sequelae to the patient. That is the primary important thing that we have been stressing upon. I think the whole talk of Dr. Anand sir has been on the fact that whatever surgery we do, we should achieve maximal resection. Yes, that is important. But as he already said in the first introduction itself, that in neurosurgery, unlike other oncosurgeries, we cannot take a margin. Normal oncosurgeries, normally we say, okay, how much of free margin, tumor-free margin have we taken, and we send it for biopsies and see, okay, 1 centimeter we have resected. But here, I know about neurosurgery because as an anesthesiologist, I've been working very closely with neurosurgeons, and I've seen that they always try to do minimal so that they do not go beyond the tumor border margins and actually cause more neurological sequelae, long-term sequelae to the patients. But with the kind of technology that sir has shown now, with the awake craniotomies, intraoperative neuromonitoring, and more importantly, the functional MRI, which will actually show us where the tracks are going, where the tumor is, and how beautifully it's been shown that how the actually switch areas where it's supposed to be anatomically, but when you do a functional MRI, you see that it's been shifted, and that gives you a window from where you can go and operate and achieve very good resection. I think it's been a very, very informative and I'm sure enlightening talk. And to all those who are pursuing neurosurgery, it is a beautiful talk. And those who are not pursuing neurosurgery, for all the medical graduates, also it will be very important for you to go through, listen to this lecture, because you will be coming across many patients who will come to you for second opinions, or even if your own kith and kin are involved, you will be able to direct them to the best possible surgical centers where such fantastic work is being done. I have the privilege of working with Dr. Anand sir in our hospital, and I have seen these surgeries, and it's real amazing recoveries that these patients have made. With this few things, I would like to open the session for questions. Any questions to Dr. Anand are welcome.
I don't see any questions in the chat box.
I don't really see any questions. There are no questions who have been posted in the chat box, sir. But if anybody is interested to ask any questions, I think we can open up for questions. Okay, if there are no questions, I think we will conclude the session. And once again, I thank Dr. Anand Balasubramaniam for taking time out and making such a wonderful presentation. This will definitely go a long way in teaching our students. And I thank Anbai again for creating this platform for education of the students. Thank you very much.
Yes. We from Anbai thank Dr. Anand Balasubramaniam for his time, and Dr. Vishnu Reddy for moderating the session, sir, and to all the participants. Okay, and this will be uploaded onto our website as well, where it will immensely help a lot of students to gain information, sir. Okay.
Thank you. Thank you.
Thank you once again from Anbai, sir. Good evening, sir. Thank you.
Thank you. Thank you.